Hi, I'm Simone Lawson, one of the Pediatric Ultrasound faculty at Children's National. Today we're going to talk about using POCUS for the evaluation of vomiting in children. We're going to review the differential diagnoses for vomiting in infants, toddlers, and adolescents, and we'll also discuss how POCUS can help us rule in or rule out certain diagnoses. By the end, you'll be able to explain the basic POCUS techniques, and you'll be able to differentiate normal and abnormal findings on ultrasound. We're going to do this through a series of cases. Dr. Ogle will pause this presentation at times so that you can have discussions as a group. Our first patient is McKenna, a 15-year-old who complains that her stomach really hurts. Here are her triage vitals, and when you speak to her, she tells you, "Last night I was hurting and I felt like I wanted to throw up, but I couldn't. And then today I threw up 3 times, but I didn't even eat anything. My stomach, it still really hurts a lot unless I stay curled up just like this." So, in addition to the information that McKenna gives you, you're able to discern that she's not had any diarrhea or dysuria. She denies having any sexual activity, and her last period was 3 weeks ago. She's never had a surgery, and when you examine her, you notice that she has tenderness to palpation at the right lower quadrant, rebound tenderness, and a positive psoas sign. So we'll pause here to develop your one-liner. And a one-liner is a one-sentence summary of what you've learned from the patient in taking their history and doing your exam. So for McKenna, I would say this is a 15-year-old female with new onset vomiting and right lower quadrant abdominal pain associated with fever and anorexia. I'm going to have Dr. Ogle pause the video at this point so that you can discuss a differential diagnosis for McKenna. The differential diagnosis for vomiting is broad. You may have come up with more, but I think that you should have at least included the following diagnoses. But based on the history and physical that you've completed, her presentation is pretty concerning for appendicitis. Now, what do we know about appendicitis in kids and POCUS? Remember, ultrasound studies are operator dependent. However, a systematic review and meta-analysis showed that as ED providers, we're actually not too bad at diagnosing appendicitis, provided that we can find the appendix. So let's take a moment to talk about sensitivity and specificity, because I always have to pause and think about what it actually means. If you remember the phrase, spin rules it in and snout rules it out, that will help you determine what your sensitivity and specificity are actually telling you. If a test is specific, a positive test will rule in your diagnosis. And if a test is sensitive, a negative test will rule out your diagnosis. So based on the study, ED providers have pretty high specificity when they perform POCUS to evaluate appendicitis. So if we see appendicitis, we can be pretty comfortable with that diagnosis. But unfortunately, our sensitivity isn't that great. So a negative study doesn't necessarily mean that we can take appendicitis off of the differential. So what are we going to look for when performing POCUS to evaluate for appendicitis? The buzzwords you'll often hear are a blind-ended, non-compressible tubular structure. And the appendix is an appendage that can lie any way it wants. So finding it can be difficult, particularly if it is not inflamed or if it is in the retrocecal position. How are we going to catch our bearings? You're going to be able to identify the psoas muscle laterally, and you may be able to identify the cecum as well. As you approach midline, you'll find the iliac vessels, and you'll often find the appendix draped over these vessels. Now, as you've discussed earlier today, we have a few options for ultrasound probes. Which would be your choice to evaluate McKenna? In pediatrics, a linear probe is going to be your probe of choice most of the time. Scanning for appendicitis with this probe offers good resolution. Sometimes, particularly in larger patients, a linear probe may not offer enough penetration, and in those cases, you can try using a curvilinear probe. Now let's develop our game plan for scanning to look for appendicitis. First, you're going to have the patient lie supine. And honestly, you can have them place the probe over the point where they're most tender. Try to have it in the transverse orientation with the probe marker pointing toward the patient's right. You'll use graded compressions to help visualize the landmarks. This gradual increase in pressure helps disperse any bowel gas that may be obstructing your view. As you scan, try to view the appendix in two planes, identifying its blind end and measure from the outer wall to the outer wall. So when you put the probe on the patient, you'll probably see an image similar to this. You'll be able to notice the psoas muscle, the iliac vein, the iliac artery, and the appendix. As you can see in this image, the appendix is traversing next to the psoas muscle, which you can see in the anatomy illustration on the left. In this clip, you see a circular anechoic area that, if we put color flow on this video, we would notice would have color within the area, which indicates that it is the iliac, either vessel or vein or artery. You can see a tubular structure crossing over the top of this artery, which is the similar orientation to what's shown in the illustration on the right. So what findings are going to help us make the diagnosis of appendicitis? We talked about it being a blind-ended, non-compressible tubular structure. The diameter is usually going to be greater than 6 millimeters. And within the appendix, you are not going to see any peristalsis. There are also some secondary findings that can help you make the diagnosis of appendicitis. These include presence of an appendicolith, free fluid, increased vascularity around the appendix, or an appendix wall with a width of greater than 3 millimeters. In this clip, once again, we see a circular anechoic area. And if we did not have color flow, we may think that this is one of the iliac vessels. However, placing color flow over the area shows that there is no flow within this structure, but there is hypervascularity surrounding the area. This finding is called a ring of fire and indicates increased blood flow around the appendix. In this clip, you'll notice a large amount of free fluid represented by the anechoic area. And within the free fluid, we can see a well-defined tubular structure. If we follow this structure to its end, we're able to measure its diameter and see that it is 8 millimeters wide, indicating that this patient likely has appendicitis. In this transverse view of the appendix, we're seeing some findings that we haven't seen in the previous clips. You'll notice a thickened wall, a hyperechoic area within the appendix with some posterior shadowing. You can also estimate that the diameter of the appendix is approximately 1 centimeter. These findings are all suggestive of appendicitis. Now, using what we have learned, pay attention to structures 1, 2, and 3 in the following clip. You may have initially identified structure 3 as the appendix. However, as we scan, we can see that this area is compressible and there's peristalsis within the structure, making it unlikely that this is the appendix. However, the two circular anechoic areas, which may have initially seemed to be the iliac vessels, on further examination with scanning have a very thick wall, do not seem to be compressible, and at one point merge into an elongated anechoic area. This suggests that we are over an appendix in a curvilinear position, and as we scan back and forth, we are catching both ends, or as we scan medially, we're catching it in the middle of the curve of the appendix. Our next patient is Hayden, a 20-month-old, and his father has brought him in because he's been lethargic all morning. His triage vital signs are noted above. And Dad tells you he was really fussy a few times last night and it seemed to come out of nowhere. He finally calmed down enough to go to sleep, and I think his stomach must have been hurting because he threw up 4 or 5 times this morning. Now he really doesn't seem to have any energy and he seems out of it. On further questioning, you learn that Hayden's emesis has been non-bloody and non-bilious. He's not had any fever and he's not had any diarrhea. His immunizations are up to date and he's never had a surgery. He's generally fussy with all aspects of the exam, but you noticed a soft abdomen and non-tender testes bilaterally. So my one-liner for this patient would be a 20-month-old male with acute onset of fussiness, non-bloody, non-bilious emesis, and altered mental status. Dr. Ogle will pause the video so that you can discuss the differential for vomiting in this patient. Again, we see that the differential for vomiting a child is broad. You may have come up with more, but there's a lot of things we should consider in this isolated vomiting patient, particularly intussusception, since it's associated with altered mental status. Now, altered mental status is something you're going to be caring for often in the emergency department, and you should probably develop a quick way to go through a differential for this complaint. One of the mnemonics you may learn is AEIOU TIPS, which helps you think of multiple causes for altered mental status. However, in pediatrics, remember that one of the I's can stand for intussusception. Intussusception typically is described as colicky abdominal pain associated with current jelly stools and a sausage-shaped abdominal mass, but we rarely see this classic triad. Oftentimes, these patients present with vomiting, which can be bilious or non-bilious. If you have a young patient who has vomiting associated with altered mental status, you should consider intussusception. And it turns out, as ED providers, we're not too bad at identifying intussusception with POCUS. A systematic review showed in a sub-analysis that ED providers had a sensitivity of 94% and a specificity of 98%. So unlike appendicitis, if we do not see intussusception, you can feel fairly confident that that's not the cause of your symptoms. However, if you had very high pre-test probability and suspicion for intussusception, you probably will want to consider additional evaluation by radiology. And what are we looking for when we're trying to evaluate for intussusception? You'll hear the words target sign, hay fork sign, or pseudokidney sign. And this is when we're looking for the telescoped bowel, and in the transverse view, it'll appear to be a target, whereas when you're viewing it in the sagittal or a long axis, it will look like a hay fork or a pseudokidney sign. Our game plan is to have the patient lie supine or in the parent's lap for comfort. You can scan in the picture frame approach or the lawnmower approach. And again, you're going to be using graded compression to help minimize the bowel gas. You'll also want to try to visualize in two planes and measure the area of concern from outer wall to outer wall. Once again, let's think about our probe choices and what would be the best for this patient. When scanning to evaluate for intussusception, you can often use the linear probe. This high-frequency probe offers good resolution, and because we're scanning the abdomen of a young child, we don't require much depth. As I mentioned, there are two approaches to scanning for intussusception. The first is the picture frame approach. You'll start at the right lower quadrant, follow the ascending colon to the right upper quadrant, then go across the transverse colon to the left upper quadrant. You'll then follow the descending colon down to the left lower quadrant. The second approach is the lawnmower approach. You'll still start in the right lower quadrant, but you'll traverse back and forth across the abdomen, going from the right side of the abdomen to the left side of the abdomen. Using the notations on this clip, we can tell that the scanner is going from the left upper quadrant to the left lower quadrant. We can see the concentric layer of bowel that forms a target sign. This finding is concerning for intussusception. The area of bowel in the center of the target is the area known as the intussusceptum, whereas the surrounding area of bowel is called the intussusceptions. In this clip, they are scanning from the right upper quadrant to the left upper quadrant. And as they approach the sagittal view, you can see the layers again in a different orientation, giving the hay fork sign. Now, intussusception can happen in any part of the intestine, but it often happens where the small intestine and the large intestine meet. You can also have an ileo-ileo intussusception. However, this is not as clinically significant. You can use the measurement of 2.5 centimeters as your cutoff between ileo-ileo intussusception and ileocolic intussusception. Our third patient is Luke, a 3-week-old male whose mom has brought him in because he just won't keep anything down. His vital signs are noted above, and when you speak to his mother, she tells you, he throws up the whole bottle every time I feed him, but he won't stop crying unless I feed him. It's so much vomit now. It actually got all the way over to his dad while I was holding him. I'm really starting to worry that he's not getting anything in. As you take your history, you learn that Luke is a healthy 3-week-old. He was born full term by spontaneous vaginal delivery without any complications. His parents have been feeding him 2 ounces of Enfamil every 2 hours, and he throws up immediately after feeds, and the emesis looks just like the formula. He's had a slight decrease in his urine output and is now only producing 2 large wet diapers a day, but he continues to have daily seedy yellow stools. And on your exam, he is appropriately interactive. His abdomen is soft, although mildly distended, and he doesn't have any apparent tenderness to palpation. You also note that his fontanelle may be a little sunken, but you're not familiar with examining infants, so you're not sure about your exam finding. So my one-liner for this patient would be a 3-week-old male with forceful, non-bloody, non-bilious emesis following feeds and new mild dehydration. Once again, Dr. Ogle will pause the video so that you can discuss the differential diagnosis for this patient. And once again, the differential for vomiting is broad. It could be something as simple as reflux. However, in infants, vomiting can signify more serious problems going on, such as an inborn error of metabolism, non-accidental trauma, or some serious type of intestinal obstruction. However, based on the history and physical that you had, his presentation is most concerning for pyloric stenosis. Unfortunately, I was unable to find a large systematic review or meta-analysis for ED providers in their performance of POCUS to identify pyloric stenosis. However, I did find a study that compared ED providers and radiology providers. In this prospective study, all of the ED providers identified pyloric stenosis or no pyloric stenosis correctly. So the sensitivity and specificity were 100%. However, when we look at the 95% confidence intervals, we can see that the sensitivity ranged from 62% to 100%, and the specificity ranged from 92% to 100%. And what are we looking for in hypertrophic pyloric stenosis? We're looking to identify the pylorus, that area that is between the stomach and the duodenum. This is a muscle that's normally present. However, when it becomes hypertrophic pyloric stenosis, the muscle becomes not only thickened, but also elongated. When scanning for pyloric stenosis, you'll notice a wall thickness greater than 3 millimeters or pyloric canal length greater than 14 millimeters. You may also appreciate delayed or absent gastric emptying, as well as an exaggerated peristaltic wave. An easy way to remember the measurements in pyloric stenosis is to remember the number pi, 3.14. Now, what would be your probe of choice for scanning in this infant? I'm sure most of you said that it would be the linear probe because, again, we're going to want that good resolution, and we really don't need a lot of penetration because we're scanning the abdomen of an infant. There's not a lot of depth there to get through. As far as our approach for scanning, once again, the patient will need to lie supine or in the parent's lap for comfort. You'll begin with a transverse subxiphoid view using the liver as your acoustic window. You'll want to have the probe marker pointing toward the patient's right. Once you identify the gastric wall, follow it along to the lesser curvature of the antrum. Sweeties can help comfort the patient, and Pedialyte can help fill the stomach. In this clip, you can notice the mixed echogenicity within the stomach. You can also appreciate the pylorus coming in and out of view. In this clip, you once again can see the mixed echogenicity within the stomach, as well as the pylorus. And in this clip, you can even appreciate the rugae of the stomach. Here's another clip that's very clear as the stomach is likely filled with Pedialyte or formula. And as you scan, you can see that the pylorus is thickened. As we scan, we also come into a transverse view of the pylorus, which will appear here as almost a target-like image. If we're to pause this clip, we can complete measurements of the pylorus, and we see that the wall thickness is greater than 3 millimeters, and the pyloric canal length is longer than 14 millimeters. Here again, we have a transverse view of the pylorus, and you can see the concentric thickened muscles that form a target-like image. So in summary, kids vomit for a lot of different reasons. It's not always going to be a simple gastroenteritis. When you're doing ultrasound studies, remember that spin rules it in and snout rules it out. So if you see appendicitis, the patient probably has appendicitis. And if you don't see intussusception, patient probably doesn't have intussusception. The other helpful thing to help you differentiate normal from abnormal findings is to know your numbers. Remember that in appendicitis, the appendix is usually more than 6 millimeters in diameter. In intussusception, an ileocolic intussusception is going to be greater than 2.5 centimeters in diameter. And when you're concerned for pyloric stenosis, the pylorus is going to have a wall width greater than 3 millimeters or a pyloric canal length greater than 14 millimeters. I hope this talk was helpful in reviewing how we can use POCUS to evaluate vomiting in kids of all ages. And this time, Dr. Ogle will be able to answer any questions you may have.